Hello, welcome to Read Scholars Live. I'm your host, Dr. Mary Fleming, and current president of Read Scholars. Today, I am joined by Dr. Gloria Richard Davis, who is a tenured professor in Obstetrics and Gynecology, Division Director for Reproductive, Endocrinology, and Infertility, and the Executive Director for Diversity, Equity, and Inclusion at the University of Arkansas for Medical Sciences. Did I get all that right, Dr. Richard Davis?
That is correct, Mary.
Well, how are you? Thank you so much for joining us today.
I'm great, and thanks for having me.
So how have you been? This has been an interesting year.
It has definitely been an interesting year. 2020 started much like our typical years, but very quickly changed into, as we say, unprecedented times.
Right.
And then 2021 really started out with a bang.
Literally.
Literally. We thought we were going into, a little bit more mundane.
No.
Not with the pandemic, raging, and our political environment raging. Okay. So it's been quite interesting.
And, one of the, for those who are actually looking at us, we have Myharry in the background. And so one of the reasons I'm excited about having Dr. Richard Davis on our podcast is because she was my chair when I was a resident at Myharry. So that's where our journey together began. And she's definitely one of those giants that I look up to, who has pioneered her way through her career and definitely gave those of us kind of following in her footsteps something to look forward to and aspire to. So I felt like I definitely had to say that before we went any further. So thank you for that.
Oh, thank you so much. It has been my pleasure. And it's probably one of the highlights of my career is to have people like you who really are making a difference. They're making their own impact in healthcare. And I see that across several of my former residents because I've been affiliated with a number of training programs. And I'm just so proud of what you guys are doing. I have to tell you that.
Oh, thank you. Thank you. And that kind of leads me to my first question, I guess. But so you have been in several places. You've worked in Louisiana, you've worked in Tennessee, now you're in Arkansas, and you've had different roles and different parts of your career trajectory in each of those places. And so I wanted to start a little bit and just kind of taking it back to being an REI specialist and talk a little bit about women's health, because we talk a lot about maternal health in the health equity conversation, but we don't spend as much time on women's health and specifically reproductive endocrinology and infertility, which you might have to define for people, because I know that's a subspecialty that people don't always, infertility people sometimes get, but the reproductive endocrinology can be a little elusive to some. So why don't you just tell us a little bit about that and a little bit about disparities in women's health and kind of how that evolved through your career.
Okay. So, reproductive endocrinology, I like to think of it as ambulatory gynecology and infertility, because a lot of what we deal with are conditions that affect women's reproduction, whether it's from an endocrinological perspective or whether it is structural, things like fibroids or endometriosis. And we really cut across different stages of a woman's life, from adolescence, where some REIs really focus on contraception and adolescent health, to reproduction, which is probably the bulk of what we do in the fertility world. And then we go into menopause and beyond, which the North American Menopause Society, I served on their board for a number of years and was their scientific chair for the last couple of conferences that we had. But so we really cross all stages in a woman's life, focusing primarily on those entities that affects, or those conditions that affects reproduction.
And so I know, especially at Myharry, when that's one of the, well, we can talk about Myharry a lot, but we talk a lot about health equity and health disparities there. And there's a research center there that specifically focuses on women of
Yes.
color, right? And I know a lot of women will often talk about fibroids and fibroids effect on health in general, but also their reproductive health. And so, can you tell us a little bit more about the health disparities around fibroids and why that can be challenging for women's health in general?
So I want to take a minute, though, and talk about the Center for Women's Health Research at Myharry, because it really is a unique center, one of a kind, that was funded by NIH specifically to focus on those conditions that disproportionately affected women of color. And the research that we did on fibroids was and has been very significant contributions to the body of literature. Dr. Al-Hindi, who was my vice chair, is a really renowned researcher in the area of fibroids. He and I have both served on a number of national committees looking at fibroid and reproduction. We are working right now on it was a workforce that was through this women research, the Society of Women's Health Research, that's what it was. So they convened a group of experts, did working group, and then did a consumer group, where we really looked at the state of the basic science. What do we know about fibroids? Right. As well as there's so many different newer options with regards to particularly treating the menorrhagia or the heavy bleeding that's associated with fibroids. And of course, the minimally invasive world and the ability to just remove fibroids and not necessarily have to go to a hysterectomy for women who are not interested in that. And one of the things that we know, the Southeast region of the country, more than any other region, has such high rates of hysterectomies. And uterine fibroid is the number one reason why hysterectomies are done. And clearly, women of color oftentimes are not even given an option. You do a hysterectomy.
Yeah. And we of course can go back historically speaking, and some of the things that happen not just in this country, right, in other countries where women are often given hysterectomies or sterilized, especially women of color, without their consent, and how that has affected how we interact with the medical system. And we talk about this conversation about trust in the medical system, of course, is coming out a lot now, but that's all influenced that conversation. But before we move, I want to switch a little bit, but before we move away from the clinical part of this conversation and talking about infertility especially, so kind of thinking about that, we think about women who have been either sterilized or received hysterectomies at a young age, right? And so that influences the infertility conversation. But for the other part of the conversation is access to infertility specialists and treatments, right? And so that is also disproportionate. So you speak a little bit on that before we move on to the second part of our conversation.
So one of the things that we're doing at the American Society of Reproductive Medicine is to we've convened a diversity task force. And this is really important because what we know, and we've talked about the various subspecialties, that we are way underrepresented when you start to look at subspecialty care. And it makes such a huge difference for women of color, women who are in these underserved population. Because what we find happening is, well, first of all, most people think fertility treatments is out of the reach of most underserved women, which is certainly not the case. There may be some very simple things like ovulatory induction with oral medications, which is not really expensive. Right. But what happens is in many cases, those women are not even given that information. They're not provided that information. There are assumptions because of implicit biases that we're not going to even start the conversation. They won't be receptive. They won't understand it. And so we're trying as hard as we can to eliminate some of those barriers for women at every socioeconomic status. And the way that we do that, the way that we influence that, is really to increase our pipeline, to increase diversity. Because while we recognize we'll never have population equity in terms of our healthcare workforce, but having us be part of that conversation changes the dynamics of those conversations and brings to light the things that really needs to be addressed. And you can't just let it drop. So that becomes a critical conversation.
And that's perfect segue. So I wanted to talk a little bit more about your academic work as far as in the training process. So we talked earlier about, there's many residents, right, medical students under your belt, and there's been multiple studies, and I think a recent one that you posted not too long ago about the care differences when you receive care from someone who looks like you, right? And so when we think about the population of physicians across the country, we know that underrepresented minorities are still very underrepresented, hence the term.
Very.
And how do we improve that? How do we make that better? And it's a long process, right? When we think about making a doctor, it starts right in elementary school. So we're talking about, we got to go back 20 years in the process, and how do we improve the pipeline? And then not just getting them in the pipeline, but keeping them in the pipeline, right?
Yes.
So decreasing the leak, improving retention, and then improving retention at the faculty and professor level too. So tell us a little bit about your academic roles as you worked at different academic institutions and how that conversation has evolved.
So, we know when we talk about statistics, for Black physicians, we're maybe 5% of the workforce. When you look at academic health centers, we're 2%. So, it just gets slimmer and slimmer as we drill up, so to speak. Right. From almost the minute that I entered academic health, I was faculty at Tulane. And Tulane had what was called the MedRep program. It's sort of like the Harvard program that many of us went to, right? College summer programs to try and recruit underrepresented minority to medicine. Well, that program was HRSA funded, and they lost the funding. Mm-hmm. So when they lost the funding, Tulane supported it for another maybe 2-3 years, and then decided they were going to disband it. Mm-hmm. There was a relationship with Xavier, and most people know Xavier University, who is one of the most successful colleges in getting African Americans into medical school. So great track record. So they were going to rely on Xavier essentially to be a feeder for Tulane. And the way that I engaged in this conversation was the dean asked me to serve as the assistant dean in student affairs, which basically was the diversity officer. Now, Tulane had very few Black faculty. I had no idea just how few there were until I really started to look at this, as well as looking at our pipeline. We were at about 8% in terms of student body, and the goal was to get to 12%. Trying to essentially not just, as you said, recruit, retain, and in that recruitment is financial support. So do we have scholarship dollars? Do we have the academic support that the students might need when they enter into medical school? And are we creating an environment that's a safe environment for them? Mm-hmm. So that was sort of my foray into diversity when I was faculty at Tulane. As I sort of moved around, I was at Ochsner for probably better part of 7 years. My focus then was really establishing a fertility center, but it was also on increasing access to underprivileged patients. What kind of services can we offer that's at a lower tier? And I'm happy to say that has gotten so much better as the technology has gotten better, because we have what we call affordable IVF, which is that's a whole different discussion.
Right.
But it really is where we do egg retrieval, and you combine sperm and egg in a capsule that's put intravaginal to culture. So you don't really need that IVF lab, right? Which is an expensive cost of this. So in the capsule, incubate, and then you go back and extract the embryo from this capsule and then transfer it into the uterine cavity. That has cut IVF cost from what would probably be somewhere around 15, 20,000 to maybe about 5. So huge difference, right? So just watching some of those things happen through my career has been very encouraging. When Dr. Montgomery Rice, who was actually my senior fellow when I was at Wayne State, was dean when I was recruited for the chair position at Myharry. So when I got recruited to Myharry, of course, the focus then was, as a professional, historically Black college, clearly 90% of our student body and GME or trainees were African American. That was an amazing experience, because that's not an experience that most of us have.
Exactly.
In medicine. And so it was nice to be in an environment where, when you had conversations with your colleagues or with your administrators, you were very comfortable knowing where the conversation was going was not based on racism.
Yeah.
Right. You could have some very truthful conversations and work through deeper level issues without worrying about what some of the repercussion or ramification might be of what you said. So loved my experience at Maine. And then my husband, who is a urologic oncologist, was faculty at Vanderbilt when I was chair at Myharry. Well, he interviewed for the chair position for urology for University of Arkansas Medical Science. And I have to step back and say, he is an Arkansan. He's a native. and actually, I stole him from UAMS because we met when we were freshman medical students. I was at LSU in New Orleans. He was here in Little Rock. And so we dated sophomore year back and forth, and he tried to get me to transfer. And I was like, no way am I moving from New Orleans to Little Rock. That is just not happening. So he says it was the longest recruit to Arkansas he has ever encountered.
I love it.
Because 25, almost 30 years later, right? Here we are in Arkansas. He transferred to Tulane in junior year and finished and graduated from Tulane Medical School because I wouldn't come to Arkansas. So now I'm sort of paying back, to Arkansas some of what he feels is his responsibility, right, in giving back to the state. So that's how we ended up here. And it's been interesting because it is very, very different. You can see UAMS in my backdrop here. So it's a very large academic institution. We have 5 colleges, the College of Medicine, Nursing, Pharmacy, Health Profession, and College of Public Health, along with graduate studies and a number of different institutions, the Cancer Institute, digital health, it's fairly expansive. So when I first got to UMS, I entered into really what was just a clinical role. But last year in January, I transitioned into a more administrative role as executive director for diversity, equity, and inclusion, which really gets me into the discussion about pipeline programs. We have really a menu of pipeline programs from kindergarten through medical school. And it is critical, as you pointed out in the earlier comments, that we really start at that level, because we lose so many talented students along the way. And even with these pipeline programs, we still lose, because we talk about leaky pipelines, right? Because it's difficult to keep students engaged all the way through. With our kindergartens, we start with the Junior STEM Academy and Senior STEM Academy. Those academies have actually received recognition and accolades from AAMC. Our director is phenomenal. And then we pick up with high school with our pre-health scholars program. So during the summer, we have students come on campus and engage them. Obviously, this past summer, we were not able to have students on campus because of the pandemic. So it really forced us to pivot into a virtual world and turn all of our programs virtual, which was a huge learning curve that we did in about 2 months, maybe. So we had really trial by fire. We had a lot of learning that we did over that summer, but I thought it was very critical that we keep those programs going, because one is it helps to continue engaging our students all along those pathways, and it also affords them, we pay student stipends from high school through college, right? Because you think about the students that we're trying to recruit, those students have to work.
Right.
And so if we're asking them to engage in the summer, they can't work. So we have to find some kind of way to offset, to compensate them for what they're having to give up. As we say, lost opportunities, right? Or opportunity cost. So our programs do that. We have, aside from what initiatives we have within diversity, equity, inclusion, Arkansas is a very rural state. So we also have regional programs around the state that offers various pipeline programs. Most of those also start at elementary. They're not necessarily focused on diversity in terms of race and ethnicity, but diversity in terms of rural and lower socioeconomic students. So, you know, we have a really rich pipeline program that I am incredibly proud of, and we are constantly increasing that. We just got funding from the state through TANF to be able to really create a robust pathway program, which will increase our reach with all of the pipeline programs from K through college. And HRSA funding was also increased this year. So we're able to increase the number of students, the number of students that we reach and that we engage. And then for our professional students, our medical students, we support many of the organizations that really focuses on professional development and networking opportunities for students of color and ethnicity, like SNMA, which we all were a part of as students. We also have SNAFA, which is the counterpart for pharmacy students. And we have the Latin Medical Student Association chapter that we just started. And then there's LULAC. And then we've got an LGBTQ alliance as well. So we try to be very conscious about trying to be inclusive across our campus.
And just to underscore a couple of things. So I often call myself a product of the pipeline, right? So I did all the programs. If my mother could find a program that she thought might be useful in any stretch of the imagination, I was in it. And so that became part of my educational journey, was, you know, finding something in the summer that would be useful and help me get to where I was trying to go. And I think, you know, I think about all of them are great, but I think about the programs that I did in high school, and we were often together. So the underrepresented minority students from the city and the rural students from, you know, these counties in Kentucky that I didn't know existed, it's up on the map, were often together. And I think that gave me a greater appreciation of health disparities aren't really about color, right? It's so much deeper than that.
Yeah,
and so
it is
that
definitely
was part of my journey, right?
Right.
And then, you know, kind of thinking about going to Myharry, as you talked about, and really feeling affirmed in that situation. And it's one time where you can, I always say, start the conversation in the middle, because you know there's a underlying layer of understanding, and you don't have that pressure of being unseen in the middle of the conversation. And then kind of thinking to the next point,
or having to explain your perspective,
right? Like, why are we talking about this?
Right.
And then that support when you're outside and you're in a majority institution, and how important it is to have these organizations that you specified that are there to hold you up when, you know, there are those who are trying to tear you down, and those are so important. And I think all of those were important for me to be able to make it through the training process. And I don't know if without any of those that I would have made it through. Like at certain points, you know, that was what was holding me together.
And that's probably true for many of us. One of the things I failed to mention that we are launching on this Friday is a virtual mentorship platform. Okay. So, you know, there is the National Research Mentorship Network, which is an NIH-funded network. NIH invested $21 million in creating this mentorship network to try and increase underrepresented minority biomedical researchers. Well, we are leveraging some of that because it helps to do training workshops for mentors, not just in research, but in clinical. Well, one of the things that we know is mentorship is critical to our success. None of us got here without having mentors who helped we stand on their shoulders today, right? And so we're creating this network, a virtual platform we're going to start with our medical students, residents, junior faculty. But the hope is that, as I talk about our pipeline programs, right, that we incorporate those students into this virtual platform so they get mentorship along the way as well. And if there is ever a silver lining to COVID, it is that. We've all had to pivot and learn how to do and live in this virtual world. And it has really removed the walls. It's removed some barriers that we, you know, before now would never go past, right? Yeah. So blow up the walls. We can reach you no matter where you are, okay? And so that's exciting.
Yeah, that's very exciting. So I'll have to stay tuned and see how that develops. But I know you are a woman who wears many hats and probably have many places to be. So I don't want to keep you long. And as we close, I think that is a great segue to closing. And I often think about 2020 as the year of the pivot, right? It pushed us to be creative. It pushed us to be innovative. It pushed us to be fast, right? So some things that we had on the table, but we had to, like you said, we had 2 months, you got to get it together, right?
Let's go.
Let's get this done. So as we kind of starting this new year in 2021, what are you looking forward to or hopeful for, either personally or professionally, you know, as we're kind of starting a new year with new information?
Well, personally, I have two college-age kids.
That's crazy.
One of whom is.
I remember them. I was like, anyway, sorry, I digress. I was like, it's so weird that they. I know. I mean, for you, I know, but I'm like, oh my gosh. Anyway,
I'm looking at getting a raise. One is graduating from Tulane, so that's a huge raise for me. Professionally, we talk about being lifelong learners. We are really lifelong learners. And I'm about to engage in a health equity course through Harvard starting next month. And so I'm excited about that. I did the Cornell Diversity and Inclusion certification program. And so the ability also to be able to use some of that knowledge gained in the work that we're doing right now, right? To be able to really elevate how we deploy our programs and the effectiveness of our programs. So I'm excited about what we can do and what we can accomplish this year.
I like it. That is a perfect place to end. Lovely optimism and challenging us to continue to think big, do more. And there's so much more. And even in a year that so much happened that we can think what was negative, but we can dwell on the negative, but there's so much positivity that also happened and gives us so much opportunity to do so many things in the future. So I am looking forward to that with you.
I like that. I think I reflect back on Amanda Gorman's poem, right?
Yeah.
We have to be brave enough to see the light and to be the light. And so that's what I think all of our challenges are, is to really embrace that. Because there's so much that we can do and must do.
Indeed. So see the light and be the light. Thank you so much, Dr. Richard Davis. It was a pleasure as always.
Absolutely. Thanks, Mary, for having me.
Thank you for listening to Read Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.